The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our LymphCast show, episode 63 tonight. Just a reminder, we are on every podcast platform under the sun, Apple, Spotify, you name it, we're out there. We're also on YouTube as well. You can check us out anytime. The show is sponsored by VitaSupport MD, makers of Lymphatic Formula 1000 and Vein Formula 1000. You can find us at VitaSupportMD.com and check out our show website as well, LymphCastNetwork.com. And if you have a question for anybody on the panel, you can send us an email at hello@LymphCastNetwork.com. Now let me bring in, we don't often get her on the show, but she's here tonight, the producer of the show, Dr. Diane Chubak. Dr. Diane Chubak, hello, greetings, and take it from there.
Thank you so much, Paul. Today we're having a really great show because it's about some of a really, really essential part of self-care, where there's lymphedema, lipedema, any lymphatic disease involved. The physiology is a very delicate balance, and we're going to talk today about nutrition and how incredibly important it is, especially when in these disease states, a lot of the other treatments that are available can work only so good, but the nutrition is the most important thing that will help give the best success and results with this. So today's guest is going to give us a lot of this information. She's a great educator, and she's going to unlock some really compelling information about a course that she put together. So it's the kind of thing where, you can get this information, you can follow these tried and true guidelines, and it's just wonderful. We're going to have a wonderful time with a lot of great information today.
All right, very good. And let me go ahead and bring in our panel. Now, from Arizona, scientist and author, Dr. Monica Glavitsky. Hello, Dr. Glavitsky. How are you tonight?
Everybody.
Good to have you with us. The founder of this show, the founder of the Chubak Vein Center, and also the founder of VitaSupport MD. And he's an author in his spare time. Physician surgeon, Dr. John A. Chubak from New Jersey. Hello, Dr. Chubak. How are you, sir?
Hi, Paul. I'm doing fine. Thank you.
Good to see you again. And we are off and running. And I will turn it back to you, sir. If you'd like to begin the questions, take it away.
Well, I would first like to introduce, it is my honor to introduce Leslyn Keith. Leslyn started out at the University of Utah, I believe, got her doctorate in occupational therapy. She's also certified lymphedema therapist, LANA educated and certified. And she comes to us with, oh my gosh, she's just an unbelievable educator. An educator of healthcare people that then will educate patients, and an educator of patients. She has written a couple of books. She has a wonderful website that is just going to bring about, incredible information. It's such a great resource. So I would love to welcome Leslyn Keith, Dr. Keith. I'd like you to start out by telling us a little bit about yourself and how you built your career over the last 20 years taking care of patients, especially with your interest being in managing obesity and weight-related issues with lymphedema and lipedema, and what inspires you to do what you do and the incredible education that you offer everyone.
Thank you. Thank you so much for a nice introduction. I became an occupational therapist in the mid-90s, wanting to actually specialize in lymphedema. And so I almost immediately from becoming an OT really went into that specialization and started treating lymphedema. And at that time, I really didn't know anything about nutrition. And I'm working with my patients who seem to be overwhelmingly obese. And that is kind of reflected in just the usual adult population in the United States, is that now over 67% are overweight and obese. And I saw that it was making their lymphedema worse. And it kind of made it so I almost couldn't have any effect. I do my normal complete decongestive therapy, massage, MLD, compression bandaging, skincare, exercise, and I wouldn't really get better like I would from my other patients. And so I started looking around for what I could do, and finally came upon carbohydrate restriction, low carb diets, ketogenic diets that were very good for treating obesity. And all the literature seemed to say when the patient lost weight, their lymphedema got better, it got easier to manage. I thought, perfect, let's start doing this. And so first I did it myself. I changed that way of eating. And the first thing I noticed was, wow, I don't need to stop for lunch. I could see it keep working because I still had plenty of energy. I wasn't hungry, and I could just eat those 2 meals a day before work and after work, and I was fine. And so then I started asking my patients if they would like to try it. It was interesting how people were very resistant to changing the way they eat. This is not an easy thing, and it was easy for me. And so I thought that was the most astonishing thing that I saw first, is that diet is not an easy thing to change for most people. So I was playing around with that. And then I thought, I want to have some more research to show that this way of eating, specifically cutting down your carbohydrates, that this would be good for people to lose their weight, and then hence their lymphedema will be better. And so I couldn't figure out how to do a study unless I got my doctorate. So I enrolled in the program at University of Utah, as you said, and they let me pretty much design my own program. Now, you really shouldn't do this. You shouldn't go in with your study already designed, and this is what I'm going to do. You really should, do more research in the field and then decide what you're going to do. But I came in there with it all planned out. And I actually did do a small pilot study with 10 of my patients who had previously been treated by me, and they also had obesity and lymphedema somewhere on their body. And so I made this. It was a lifestyle modification program. The main part was to adopt a ketogenic diet, but we also focused on sleep, stress management, exercise, time management, all things that can go into a lifestyle program. And the results were astounding. And so that really started me on the road to saying, nutrition is the piece that we're missing. We can't just say we're going to do all these physical treatments. And some people were using medications, some people were using surgery, and then they were doing CDT, but that wasn't enough. We had to also deal with what people were eating every day. So that started me on the road to finding out even more stuff. And you know what? There's so much research now. My little paper, my study came out in 2017. There's been an explosion of now papers about using some form of carbohydrate restriction and either lymphedema or lipedema. Everybody's talking about it. And for about 5 years, it was just me doing it. And I think that people were not believing me because I'm just a lone voice out there. Now, a lot of people, or a lot of researchers are out there talking about, a lot of clinicians are using this in their practice. So I'm very, very pleased.
Could you please explain in detail what does it mean, ketogenic diet, in practice? How do you conduct it? And
Sure.
The second question that I have, is that indicated for all of your patients, or you have some restrictions in the specific cases?
Mm-hmm. And actually, I'm writing a paper right now about that, because it is one thing that I found when I did my little pilot study. I thought that I would just tell people that here's what the diet is, here's the science behind it. And I figured everybody would just do it because, the science showed that it was good. And it really didn't work out that way. So And also what I'm finding too is that you really have to take a holistic approach when you're looking at diet and making diet changes, because it's not just the physical of eat this, don't eat that. It also is, what's your cultural influences that really influences what you eat? What about just socially? And if you're going to be eating differently than everybody else sitting at the table, how does that influence you? And then, as you were saying, Monica, that if you have certain other conditions, do we need to modify how we're going to, the basics of the carbohydrate restriction? Do we need to modify it because of these other comorbidities that you have? So I think there's a lot that goes into making an individual eating plan, but in general, a ketogenic diet is just carbohydrate restriction. And a lot of people think of it as also super high fat, because originally when it was used for managing seizures with epilepsy, it was very high fat, because you had to have that really high fat to keep the kids from having seizures. Now we're seeing that the main thing that works for many other conditions or just general health is just keeping the carbs low. And that means sugar and starches, bread, potato, pasta, sugar, like in candy and soda and things like that. So keeping all that stuff low. Now, what do we want to do for you individually? How much protein do you need to have? How much fat do you need to have? And that can be very individual, but we start out with the basic thing of just seeing where your preferences and your other influences, how low can you have your carbohydrates go? And then we work out the other pieces from that.
And so do you mean, so you decrease all the carbs, but you adjust it for the patient cultural diet and specific situation, some health conditions and so. But I mean, do you go like, for example, with Weight Watcher, that you have this points and that you want really to decrease the number of calories that are in?
Yeah, no, there's no calorie number at all.
No,
it's pretty much eat ad libitum. Yeah, eat until you're full. But we give them patients a certain food list to start with. You have these foods, and what I tell them to make it simple is, if you don't see a particular food on the list, don't eat it. But there's a huge variety of foods on the list. So you won't see bread on the list. You won't see pasta or rice or something on the list. But you will see any kind of meat or fish or chicken. You'll see any kind of fibrous or non-starchy vegetable. You'll see dairy. You'll see, so those are the things. And now, well, do you have a lactose intolerance? Okay, we're not going to have those dairy foods. Are you prefer to be more plant-based? Then we're not going to be doing the steak and the other things. So you figure out now, based on their individual needs of this wide range of foods that are suggested, what's going to work best for that person. I had a couple of patients that tell me, well, I can't do a ketogenic diet. I don't like avocados. If you don't like avocados, don't eat them. You don't have to eat, you don't have to eat certain foods. We want to make sure that you get your carbs low enough so that for you, your symptoms are manageable or less severe. And it's also pleasing for you to eat, and it's satiating. You get all the nutrients you need. And so sometimes that can take a little bit of tweaking and work to arrive to what is going to work best for that individual person.
What about fruits?
So as Dr. Eric Westman says, fruit is nature's candy, and you just don't need candy every day. So we do say that to start out with, we don't do any fruit at all, but eventually you can add some of those really low glycemic fruits like berries, peaches, things like that. I would tell my patients, I suggest you don't ever have bananas, apples, oranges, because they're very high sugar, but if sometimes you might have a little bit of that. For someone who already has type 2 diabetes, they would be more strict on not having those. But maybe someone who is pretty carb tolerant and doesn't have problems with every once in a while having some of nature's candy, then they could be more liberal with that.
So I'm so pleased with you being with us on the program, because we just had the very specific question about the nutrition recommendation for lymphedema and lymphedema from the listener of our podcast, who sent us the specific question: what should we do with diet?
Yeah. And I always recommend to people that if you're going to drastically change your diet, make sure you check in with your doctor, because particularly what we're finding with going a low carb or ketogenic, your medication needs change. You might be over medicated because now you don't need as much blood pressure medication. Maybe you don't need maybe you're taking metformin for pre-diabetes. And so you need to have someone who's monitoring you and checking in your symptoms and how you're doing to make sure that those things are addressed. But if you're going to be doing a more gradual change, maybe this week I'm just not going to have any bread and just start out with that, then it's not going to be as imperative that your doctor's on board. But I think it's always a good idea to let your doctor, your other healthcare providers know, I'm going to be trying this other way of eating and see how it works out for me, so that they have some good monitoring.
Okay, and so you've put a lot of this information in your book, and the book is entitled Ketogenic Solutions for Lymphatic Disorders. Tell us a little bit about the book.
Sure. And this book I wrote after I did my study, because I wanted to put together this package for lymphedema therapists to be able to run a lifestyle program just like I did for my pilot study. And so, and I talked to colleagues and they said, well, no one's going to understand how to implement your lifestyle program if they don't know the science and the reasoning behind it. So I wrote this book, and it was really intended for clinicians to help them see how they can integrate nutrition, especially ketogenic nutrition, in their practice. But in reality, it was mostly patients who read the book. So I think patients were trying to find other ways to make their lymphedema easier to manage. So a lot of patients bought that, and I thought, well, then I need to do a second book that is going to be a guideline that could be for patients, but also be for clinicians. And so the Lymphatic Code, my second book, talks about all the lifestyle impacts on lymphatic disorders. And so besides nutrition, which I still talk heavily about using ketogenic or at least carbohydrate restriction, but I'm also talking about stress management. I'm talking about exercise, talking about sleep, all these other impacts that lifestyle impacts that you can have on your lymphatic system, and hopefully enjoy better quality of life. And so the Lymphatic Code still talks a lot about the ketogenic lifestyle, but it also has all the other lifestyle impacts in there as well.
I love how this book starts out with evolution, because you honestly started right from the beginning. If someone is newly diagnosed and they don't know what this disease is or what, this is just such a beautiful resource for them to just understand, how it came about, why this lymphatic system is so important in our bodies and where it came from, why we have it. Just explaining to everyone the way, the anatomy, the physiology and everything. And it's such a great resource, especially, like I said, for newly diagnosed people.
Great. That's good to hear. I have to tell you about this paper that just came out, and it's talking about the lymphedema microenvironment. And it's just what I'm trying to communicate in my book, that microenvironment of our tissues, it's almost predisposing people to get secondary lymphedema because of their cancer treatments, because of obesity, because of immune dysfunction, all this stuff that's the lymphatic system is heavily involved in, but it's changing that microenvironment that is increasing their risk for lymphedema. And this paper, it talks about potential interventions that we can do. So it's not just setting up the problem, it gives us some ideas. And they're basically the ideas that I promote in my book, The Lymphatic Code. So improving our sleep, becoming more stress resilient, losing weight, all these impacts give us a better microenvironment so that if we don't have lymphedema, but say we're about to undergo treatment for some type of cancer, maybe we can prevent ourselves from having lymphedema. Right now, all we say is you might be able to reduce your risk, but once you get lymphedema, you've got it the rest of your life. I think there's a potential now that we might be able to actually prevent or reverse it by improving that microenvironment in our tissues.
That's really fascinating. What say you, Dr. Chubak?
I'm taking it all in. It's
Being a little too quiet there.
No. I have geniuses speaking. Time to be quiet when everybody who's so bright is speaking. Fascinating discussion. Have lots of thoughts and questions and ideas. The last thing I was thinking about was what Leslyn just talked about the microenvironment. And I might be passing this back to Monica actually in the thought stream, because discussion of the microenvironment had me thinking about the microcirculation. And Monica and I talk a lot about the microcirculation, and the microcirculation having three components: the arterial microcirculation, the venous microcirculation, and the lymphatic microcirculation. And one of the things that Dr. Glavitsky educated me on a number of years ago now was what we both now admire as a brilliant study, which was the hamster cheek pouch study, which was an ischemia reperfusion model looking at the microcirculation and hyperpermeability that occurs after ischemic injury in tissue. And it's one of the areas that MPFF and other venoactive agents were looked at to see what impact could they have on that microcirculatory injury and hyperperfusion milieu, for lack of a better word, this micro environment, and the inflammatory process that goes on in that process. And now we know from our colleagues like Dr. Mark Moline, the glycocalyx, and the injury at the endothelium, and so on and so forth. And how, now that of course was an ischemia reperfusion model, which is fascinating. It was a brilliant model in a living hamster, which was really effective. But you wonder, Monica, if I can pass that thought process back to you, how do you think insulin resistance, hyperglycemia, and so on and so forth feed into the pro-inflammatory aspect of that? And that's kind of, I'm putting two and two together in my head, is the point.
Well, first of all, I think that they are all, when we talk about microcirculation, we have to have in mind that in fact that microcirculation is a common platform between small arterial vessels, veins, small veins, and lymphatics. And all this is like in the bath of the interstitial tissue, and whatsoever is happening to one or another player influence the other players, of course. And especially when we have the situation of obesity or diabetes, this is associated with the production of the inflammatory factors, and all this is going into the interstitial tissue influence microcirculation.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
I'm sorry to interrupt, Monica, but of course, I'll throw in there, and in that overall process that you're describing, I know this is something near and dear to your heart, so I want to throw it in there. The free radicals and the superoxide species, which then lead into more inflammation.
These are all the reactive oxygen species that tends to deteriorate whatever tissue or endothelium, wherever we have the superproduction of these these agents, we will have trouble sooner or later. And of course, like we have all kind of intervention possible. Vein-active medications such as PFF are one of the way, because of course they act limiting the inflammation and limiting the production of the oxidase and production of the oxygen reactive species, and we have the several
reducing oxidative stress.
Yes, but certainly the diet that you describe has to play too. And I was like looking at the image that you have on your book, and actually it's pretty significant, because you have before and after. And before you have that not only swollen foot, but also the red skin.
Right.
Hyperemic. You notice that right away.
Yes.
Yeah.
Yeah. And I do think that this all comes together with just what you two are saying, because glucose, carbohydrates are known to degrade the glycocalyx. We're getting increased permeability in the vessels, and now we know we also have a glycocalyx in the lymphatics. So you have the blood vessels being more leaky, and you also have the lymphatics being more leaky. We're increasing the fluid load. I remember this was probably about 15 years ago, Dr. Atelka Foley at the Foley Clinic, she said, well, of course, insulin resistance increases lymphatic load. I'm going, how do you know that? That was an amazing statement. But I'm thinking that one way that it increases that lymphatic load is that it's really compromising that microcirculation. We're making everything more hypopermeable, and we're with those inflammatory markers as well. And we know that lymphedema and lipedema are inflammatory conditions, chronic inflammation. It's all that stuff is sitting in the tissues, and it's stagnating and not getting into circulation.
Absolutely. Another thought that I have a couple of other thoughts, one of which is going back to your very early statements about how difficult it is to change patients' eating habits. But that's a subject that's near and dear to my heart, that we talk about kind of in my other world of Chubak education and the books that I've written on the human mind and the conscious and subconscious, and how much. And I loved what you said, that so much of eating habits, not only the foods, but the way that we eat, the volume of food that we consume, the times that we eat, the frequency with which we eat, much of this is cultural. And it's different from country to country, generally speaking, but even within a big nation like ours, it can be different in the South versus the North versus the East versus the West, et cetera. There are cultural, habitual behaviors. And one of the things I talk about in this work on the mind, I use what we call the stickman model or the mind mouse model with the conscious and subconscious mind. The subconscious mind is the emotional mind, not the intellectual mind. And so those behaviors that we adopt, now we're talking about eating, but that's a major part of cultural life, is eating, something that we do with our friends, our family, our coworkers. We do it in public. We do it in front of other people. We do it in private. It's a hugely emotional aspect of our life. We're in love with that. Monica's in love with her mother's pierogies. I'm in love with my father's shish kebab. You're okay? Diane's in love with her grandmother's gołąbki. So you fall in love with these things because it's associated with good feelings, memory, and so forth. That's part of the reason it's so difficult to change those behaviors, because the intellectual mind says, yes, I understand, I get it. That's easy. I see it. But the emotional mind that we can't hear is saying, no, 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 we're not going to change. That's not how we were raised. That's not what we like to eat. So that's a fascinating part of the subject, which leads me into this difficult question, I think. Interesting, but difficult. When I look at the history of the world and you look back at what kept most of mankind alive, because most of us as physicians, we were taught very much the mathematical model, the calorie model of weight management. That calories are currency, and it doesn't really matter whether you get $1 million in singles, fives, tens, or 20s, you still have $1 million. So it doesn't matter if you're taking 3,000 calories a day in the perfect pyramid, the old pyramid of balanced diet with fruits, vegetables, carbohydrate, fat, protein. So the point I'm getting at, historically, what kept mankind alive in the different corners of the earth, huge swaths of Asia, China, India, Japan, Korea, etc., the Middle East, lived on white rice. Huge parts of the Western world lived on white potato. And then there were areas, let's say, in Italy and also in Asia, where it was noodle production. Now in Italy, we call it pasta. Pasta was a staple, wheat-based. So my question is, if obesity was not a problem for 2,000 years or 4,000 years of recorded history, when people, because meat was very scarce, expensive, difficult to raise, difficult to hunt, difficult to capture. Why has obesity become such an epidemic in recent times, and we look to carbohydrate as the source of the problem, when it seems to me that for 3,000 years mankind was subsisting on large amounts of carbohydrate because it was cheap and it was plentiful? Is there something else? Is it lifestyle, exercise, environmental, chemical exposure? What are your thoughts, Leslyn?
So I think that if we really look at an accurate picture of what people were eating historically, it was much more animal sourced, especially when we started raising the animals ourselves, and then we could slaughter them or have their milk or have their eggs easily. We really didn't have a lot with plants. Most plants were poisonous. There was difficult to eat a lot of plants, unless you were in the tropical regions and you can have fruits. A lot of plants were, and there wasn't much nutrition in the tubers and the things you can dig up. Our diets were primarily animal sourced. It was only in the last 100 years when people were trying to mass produce foods and have them last as we shipped them to other places, those carbohydrate foods were very stable and they could ship off. I mean, hardtack for the sailing ships, this very hard type of carbohydrate food that they subsisted on. So, and when you look at the cultures where we knew what they were eating, for instance, the Egyptian cultures, it was a very wheat-based culture. And you look at the historical the remains, they all had bad teeth. They all had a pot belly. The men had gynecomastia. So these were common things in that wheat-based culture. But you looked at the ones that were animal sourced, and your worth was how many cattle you had. That's how you had the status in your village. Eating those animal source foods, those people did not have cancer, diabetes, or any of the chronic diseases that we have now. So I think that it's much more accurate that even with early America, with the people coming over from Europe and living here, they definitely tried to farm, but it was hard to get a farm started and have lots of plants to eat. They were hunting and they were eating meat. They were eating animal sources. So this was not, you couldn't go to the store and get a package of cereal or pre-made bread or something like that. If you wanted bread, you had to make it yourself, and it was an arduous process. So I think that it was much more animal source foods before we started getting this mass production of foods and having huge areas of cropland.
How about the 1 billion vegetarians in India?
It's true, and you know what, we have almost 1 billion people with diabetes in India, and that's right now they're trying to do something to help that plant-based society. How can we reduce your carbohydrates, and how can we manage your chronic diseases? They're not generally obese, but they do have other metabolic conditions that are very serious. And so people who are doing completely plant-sourced diets usually have more porous bones and more osteoporosis, have more heart disease, more diabetes, all of these chronic conditions. That just a little bit of animal source foods would help. They get more complete proteins. They would have stronger bones, less diabetes, better blood sugar management, and healthier overall. I think it is a mistake to think that animal source foods are not good for you and all plant source foods are good for you. I think that we need to change our thinking about diet a little bit.
Yeah, that's absolutely crazy, because in fact, for decades, we were learning that especially for the cardiovascular diseases, you need to limit the animal origin food, mm-hmm. and you need to limit the especially the fat meat and all this. So generations in Europe were just so careful, just only lean a little bit of meat, but not much more, and always emphasizing the vegetable and fruits and fish. So that was the culture, I was raised in a way. And
if we're going to start with fish and eggs and and maybe poultry, if that's where the person is at and they're willing to do that, great. I don't think you have to eat steak to be on a ketogenic diet.
But I love steaks.
Some animal source nutrition.
Actually, I'm very much for the steaks. And the story is that I have to tell you that how much the body by itself generates some appetite for things that you need.
Yes.
I remember specifically, I escaped from Poland during just before the state of emergency, and I came to Italy, and I came from the Poland that was after 2 years of actually the edge of starvation, because you couldn't find anything in the shops, no eggs, no meat, nothing, you know, like the people were standing in line for every single food that was edible.
Mhm.
And I came to Italy, and the first thing I did that was never the case in my life, I asked for the bloody huge steak. You know, I felt like an animal almost, you know, and I devoured it. You know, how much this is crazy what is happening in your mind. And I agree that in fact, in having that opposite attitude, like pushing towards vegetable diet only, you know, vegan and all other diets, it's not good for you. We are not, our body, it's not constructed to have it.
Mhm. Yeah.
Well, we evolved with canine teeth for some purpose, for sure.
Right, right.
Clearly, we were carnivores.
Yeah.
And my darling wife Diana is going to prove to the world that you don't die young from salmon toxicity, because she's eaten so much salmon. It's her go-to.
Salmon.
She's so
meat.
bright.
So she's done a
Omegas.
she's done a study with an N of 1. But if that means anything, you know, the power of the study may not be there great. But no, it's a fascinating subject, and I can attest. When I was doing open heart surgery, the first 6 years I was in practice, strictly open heart, here in New Jersey, we had a big East Indian community from the subcontinent, many of whom were vegetarian, of course, but many of whom had severe coronary artery disease, even though they were very, very slim and very tiny people with normal or even subnormal BMIs in many cases. But there are other dietary factors and obviously genetic, ethnic factors that can be playing into all of that. For example, ghee, you know, the clarified butter that they use very, very liberally in many dishes because it's delicious and it makes things taste good. And then again, large amounts of basmati rice, long grain white rice in their diet that may be having an effect again on their blood sugar. So it's, you know, we talk about this time and time again, Leslyn, on our program, whether we're talking about venous disease, lymphedema, lipedema, diabetic complications, diabetic foot ulcer, and so forth, arterial disease. None of these things is as simple as they may seem or sound, and most, if not all, are multifactorial. It's taking many, many genetic, cultural, lifestyle components together in an extremely complicated mix that we're all, as human beings and as clinicians and physicians and therapists, trying to make sense of it all so that we can make the best decisions for ourselves and for our patients. But we obviously have a very long way to go. But it's a really, really fascinating discussion. Tell me what because I'm so engaged in this field now. We just came back from an interesting meeting where Dr. Tom Wright, who's involved in lymphedema surgery, was talking about GLP-1 receptor agonists and things like that. One of the things I hear again and again, and I've seen it in my practice, in lymphedema patients particularly, this resistance to weight loss, fat loss, and how the fatty tissue is not the same as normal adipose tissue in the normal obese patient, and what effect you're seeing in your practice and in your experience with ketogenic diet and its effectiveness in that difficult patient population.
Yeah, and I was at the NIH meeting, I think it was in 2015, on the lymphatics. And I had my little poster of talking about my pilot study with lymphedema and obesity and using ketogenic diet. And I had a little post-it on that said, help me do more research, ask me how. And so Catherine Seo from Lymphedema Simplified came up and said, well, do you think this will work with lymphedema? And I said, I would love to find that out, because it's well documented that it's completely resistant to typical weight loss, low calorie, low fat diet, and doing intense exercise. You lose weight on the upper body and you don't on the lower body. So I said, let's find out. And so she and I started to work together. She got really into it, especially when I told her she can have butter and cream. She thought, oh, this is a good diet. So we started looking at that, and we just told women, hey, you might want to try this, see what happens, tell us about it. And we had people just responding, saying, hey, I did this and I lost, weight even on my lower body for the first time ever. And then other people like Dr. Zuba in Poland and others said, let's do an official study. And now there's probably at least a dozen case study reports, even up to randomized controlled trials in Norway, looking at lymphedema and using some form of carbohydrate restriction. I think they even did one with a moderate carbohydrate compared to really low carbohydrate, and what was the impacts. And what several of them found, and not just in Norway, but other studies, was that before they even lost any weight, the pain went down or disappeared with using this way of eating. And was it the lack of the inflammation from carbohydrates, or was it the healing properties of ketones and fats? We don't know, but I mean, it seemed to have that impact. And then the other things that started happening the longer the study went was that you had volume decreases in the lower body where they had lymphedema symptoms, and they had decreases on a body composition bioimpedance. They had actually fat loss in the lower body. And when they compared it to other diets, they had much more of these things happening in the ketogenic or really low carb groups. So it's very astounding what's happening in the lymphedema world with this way of eating. And it's, so far as with all studies with lymphedema, it's with really small sample sizes and sometimes not a control group and stuff like that. But I mean, the evidence is very, very promising. And what I find so interesting is that even though we started with lymphedema, well, lymphedema has a mouse model. And so they much rather do diet studies using an animal that has lymphedema, but there's not an animal model for lipedema. So they went straight to using real people who have lymphedema, and therefore we have just a lot more showing that it's really beneficial for lymphedema. Not as many human studies on lymphedema, but the really great one that came out of Belgium, I think just last year, that they did imaging of the lymphatics pre and post the diet, and they showed new growth of lymphatic vessels with using the diet. If they kept a certain level of ketosis, a certain level of ketones in their blood, they were growing new lymphatic vessels, and the limb was reducing in size because they had better lymphatic drainage. That's astounding.
So what was the duration of the studies? Because
so some of them were as short as, I think the Norway study they did, the first one, it was 6 weeks of using a ketogenic diet followed by 7 weeks of using a standard Nordic diet. That was probably the shortest duration, all the way up to the Belgian study that was 6 months. But typically these are of short durations. Even my pilot study that I did was only 3 months long because I wanted to finish my doctorate and get going. So I didn't, I had the intervention last 3 months, and then I did one measurement 30 days later. So they are not going as long as they should. Virta Health did a fantastic study for 2 years, and pretty soon we're going to have 5-year data coming out using this way of eating for type 2 diabetes. So it's just very hard to run nutrition studies. You can't control humans the way you control animals. So you don't know what's really happening. You know?
What are you saying to your patients usually? Are you saying, okay, so you have to wait, you have to conduct this diet and wait, I don't know, 1 month or 2 months or 3 months to see the results?
It actually gets the results very quickly, because just about any time you do just about any diet, even if it's low fat, low calorie or ketogenic, the first thing you lose is water. And so that first 2 weeks, they're seeing the pounds come off. That's quite motivating for them to continue, especially, and this is especially with my lymphedema patients, that the pain is magically hugely reduced, sometimes in the first 2 weeks, and sometimes even resolved in the first month. And there's a certain faction in Europe that says that if you don't have pain, you don't have lymphedema. And so we got a bunch of people that are using a ketogenic diet that no longer supposedly have lymphedema anymore because the pain is gone. The weight is coming off slower, but it does come off. So when you have things like that happen, right away losing a bunch of water weight, having your pain be very decreased right away, then that's it's life-changing and huge for your quality of life. And it's very motivating, and you want to continue.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
That's incredible. Now, you have put together, given all this research that you've been involved in, all the research you're citing right now, you have organized a program. And it seems as though the program is geared toward teaching healthcare professionals to teach their patients. So tell us a little bit about, and I believe this is called the Lymphatic Lifestyle Solution.
Yeah, and it really is, it's for the patient. Originally, it was a program designed to be run live. And so it's basically what I did in my study. And so it's a 12-week, once a week session program. And I put together a package so that lymphedema therapists, clinicians, could use it in their practice with their patients. And then in 2020, we couldn't go into the office. We got locked down. And so one of the occupational therapists, lymphedema therapists that was using my program, Robert Erkstum, he figured out how to do it online. And so he and I collaborated, and we started out with just doing just like this on Zoom. And we met once a week with a group of patients and helped them, go through this whole lifestyle program. And that was okay, but we thought, we're just not reaching enough people. So we actually made it more self-paced, but you could do the self-paced program, but then we also had all these live meetups. So you can regularly be together in a group like this to talk about whatever's happening and questions and just have the support of the community and stuff like that. So currently, Lymphatic Lifestyle Solutions is that it has that self-paced do the course, but then also meet with Robert and I and all the other people that are trying to implement these changes.
Right, that's absolutely wonderful. And so okay, so there would they find links to this on your website, which is just your name, right?
That's my name.
LeslynKeith.com.
Yes.
Okay.
Yep.
And then the links to your ebooks that we brought, that we showed here, this solutions regimen that you're putting forth, and your papers, everything, just explanations about all the knowledge that people are really craving about this, including patients
really
and
think
healthcare professionals alike.
Yeah, it really comes down to just we were talking about that microenvironment and how can we improve the microcirculation, the microenvironment to support a healthy lymphatic system.
Yeah, it's interesting. We're back to that. We've kind of come full circle. Monica and I are working on a very important paper, what I think is a very important paper for the Journal of Vascular Surgery, the Venous and Lymphatic Disorders edition, with Doctors Kakos, Doctors Nicolaides, and Dr. Urbanek. And Monica, I was reading through the current version of the manuscript, and I'm not sure if it was Tom or Stavros who wrote that section, but I love, we've been talking about for years decreased capillary permeability. This has been kind of my mantra as these venoactive agents work, whether it's MPFF or butcher's broom, horse chestnut, all of these things that we know are effective. But someone used the terminology. It's kind of, I'm letting the cat out of the bag before the publication, Monica. It may have even been you. I love this term, sealing the endothelium.
That's urbanic.
Urbanic, huh? It's really nicely put. The idea is to seal the endothelium, and then shortly after that we talk about the glycocalyx, and you can see those two things going hand in hand. This anti-inflammatory, antioxidant, free radical scavenger kind of mechanism that then, rather than thinking about decreasing the porosity, you think of it as sealing the endothelium. It's really a powerful visual.
Good visual expression.
Yeah.
Yes.
But I have another question, and it's kind of fascinating to me because I learned that you are working also on central lymphatic dysfunction, and I would like to know, first of all, could you explain the term for our audience, and secondly, how did you came to it, and what are your thoughts?
Mm-hmm. Yes, and so central lymphatic dysfunction is when our central lymphatics, the main trunks that are in our trunk, feeding into the thoracic duct, and when there is an issue with that. So, and I think that originally we were looking at it as there was some kind of genetic hereditary anomaly, and it was kids being born with, very, very swollen because their central lymphatics were not working. But it seems to be there is a lot of secondary causes of central lymphatic dysfunction. We're seeing, for instance, with heart surgery, all of a sudden the person is getting hugely swollen at the base of their neck, at the nodes there, and lots of swelling in the chest that is hugely painful after their surgery. And then other people who are getting, for instance, gynecological cancer surgeries, just that huge bloating in the belly. What is this coming from? And so Dr. Max Itkin and others in Philadelphia are talking about that we're getting some kind of injury to those central lymphatics, those main trunks and the thoracic duct. Somewhere in there is getting an injury. And so stuff is going the wrong way. And when you get that going, the lymphatics flowing the wrong direction, you're getting organ dysfunction. You're going to have problems with your liver, your kidneys, your lungs. These people are coming up with severe difficulty in breathing. It's leaking into their belly and going to that low spot. And so you have that patient that presents to you with a really large belly, swelling in the genitals, and only later, much later, might get some swelling in their legs. I mean, we know lymphedema starts in the leg and then goes to the genitals and the trunk. For this person who has a central problem, it starts in the trunk, and they can have severe problems with organ function. They have a lot of GI upset. I mean, a major portion of Dr. Aitken's patients, he said that their major symptom is that really distended belly and abdominal pain. And the ones that have the leak up here, difficulty breathing and the swelling up in the upper trunk. So, and I came aware of this because of, I don't know if you guys are familiar with Kelly Bell. He is a patient that does a lot of work with Learn Lymphatic Education and Research Network. And he was in the Coast Guard, and he was treated for, I think they thought he had reflux. And so they did this treatment where they were going to inject a polymer in his esophagus. Well, it went into his thoracic duct instead. So he had this plastic polymer that just pretty much went everywhere into his lymphatics, and just got some really bad symptoms gradually appear. They didn't know it was lymphatic until probably 8 to 10 years into his disease process. And so Kelly has researched this, and then he was talking to other people that were having similar symptoms. And he started thinking that this could be a much more pervasive problem, that it seems like people who have any surgery in their trunk could possibly have this central lymphatic dysfunction. And then what do we do about it? And the main thing that has been done is that people can have a bypass with their thoracic duct. Well, actually, they started with embolism. They just would block the thoracic duct. As you can imagine, that doesn't always work out well. But now they're talking about rerouting, especially if the problem is up towards the superior end of the trunk. They're rerouting the thoracic duct to like the internal jugular or something like that. They're putting it somewhere else, just like we do with the lymphovenous anastomoses for surgery. So then that's helping. But the people that have the injury lower have a lot of difficulty, and they're not sure what to do surgically. So we're trying to think of what are non-invasive ways that we can help with this. And one way would be diet, but this particular person, although they can cut down carbs, they can't have a lot of fat, because that lymphatic system, it's responsible for removing the fat from the intestines and taking that on its way up the thoracic duct. And the person that has that central lymphatic dysfunction, they can't handle a high-fat diet. So they actually were experimenting, what is the best way to eat? They do the best when they fast. Eventually you have to eat, but we're trying to reduce inflammation by not having so many carbs, but you can't have a lot of fat. And then just talking about that microcirculation, we're also looking at hypercoagulability. And I'm wondering what John and Monica think about that, because, we got the one thing to seal that those vessels and make them not so permeable. But what about the contents of there? And if we have that thickening of the blood and possibly also thickening of the lymphatics, what is that doing for our microcirculation? And is there anything we can do medication-wise, treatment-wise, that would help with that drainage? I mean, you got all the tubes are not functioning the way they should. Is there something we can do to help improve that drainage? Because these people with central lymphatic dysfunction, they're living with daily chronic pain and difficulty breathing. It's not, it's a pretty severe condition.
Oh yeah, certainly. I really know something about it because I was working a little bit with that. We had a model of the in our research studies for the central lymphatic dysfunction with the thoracic duct. And actually, you can do it. Of course, I don't know that there was no human studies, though, so I have no answer, based on the human research, but NPFF actually had improved the circulation in the thoracic duct with the model that we were using in our research lab. Certainly, I think that we should develop much more efficient surgery. And I mean, I'm married to the vascular surgeon who was almost among the unique specimen interested in lymphatics, and he was doing the intervention to help these people. And in many cases, you can improve it. But the issue is that actually not a lot of surgeons are interested in the job because it's very meticulous. It's not bringing a lot of profit, and you have always the complicated patients.
And I can chime in there as a thoracic surgeon who trained in a very, very busy university hospital at the University of Rochester, where we had one of the busiest esophageal surgical programs in the United States, to the extent that we had an entire ICU committed only to post-esophageal surgery patients, which is almost unheard of. Oftentimes there can be in those surgeries, I shouldn't say oftentimes, but a known complication of esophagectomy for cancer and or other benign disorders is thoracic duct injury. And managing those thoracic duct injuries can be burdensome and hellacious for the patients, of course. And in some cases, the ducts can be repaired, reconstructed, etc. Peter knows a lot about this, of course. It's a low flow system, and it's not like other vascular surgery, arteries and veins. And sometimes these ducts have to be ligated, which, as you said, Leslyn, is not ideal, but sometimes it's the only management. And unfortunately, some of these patients wind up, because you did talk about post-feeding complications with pain and so on and so forth, increased drainage and so on and so forth. Sometimes these patients wind up on lifelong, what we call TPN, total parenteral nutrition, being fed through an intravenous line. So it's a very, very challenging area of medicine and surgery. Fortunately, it tends to be extremely rare, which is why people like Peter Glavitsky at the Mayo Clinic, who are getting tertiary referrals from all over the country and all over the world, can build a practice and expertise because they are so rare, complicated, difficult, that, as Monica points out, not only do people not want to take them on because of the difficulty of the surgery or because of the lack of reimbursement and the complications of the surgery, which is all valid, but most importantly, I think most physicians are very ethical, and they realize they don't have any experience. And if they hear there's a person who is capable and knowledgeable and experienced for the sake of the patient, rather than making matters worse in these difficult situations, sometimes they will refer to these, preeminent tertiary care centers and surgeons for management. But that's another subject and difficult subject. And that's the beauty of the LymphCast podcast. It seems that eventually we touch on just about everything and we get just about everywhere. I want to do one thing I'm sure we're coming to the end of our show. I want to bring in our our MC, our wonderful host, and a very, very experienced interviewer, Dr. Paul Reeves, who has his doctorate in education. Of course, I don't want to mislead anybody to think that he's a medical doctor. And that's the exact reason I like to bring Paul in as often as possible, because he has such an active mind. I know Paul has always been interested in fitness, his diet, nutrition, staying healthy, and so forth. So I feel like today was probably a discussion, Paul, in talking about the ketogenic diet and so on and so forth, where you probably have one or two questions from the so-called layperson for Leslyn.
The one question that popped into my head as you were talking, as Leslyn was talking, you mentioned rice and staying away from rice. And that's become a big topic of discussion amongst my peer group, my friends, my family. There are people in my family, I'll admit to being one of them, who really loves rice for no particular reason. There's really no taste to it. And I've been told...
That's not true, Paul. I love rice too. Rice is delicious. Okay. There's no taste to it. It's great.
Well, I appreciate you saying that. And I've been told by non-medical people in my family, stay away from that junk. One lady even said it's the equivalent to eating Twinkies and cake and pie all day. If you don't burn it off, you're going to be in big trouble. And so far I haven't been. What are your thoughts on that? Does that turn into a sugar that then does damage to your body, eating rice in general?
It's unfortunate that every carbohydrate breaks down into glucose, and it doesn't matter if it's a sweet one or a starchy one. Okay. They all end up being sugar in you. And so rice especially white rice, is a pretty simple carbohydrate that can be easily broken down into its components of glucose that is going to, for you, it doesn't seem to trigger weight gain and fat gain, but it probably is making you have swings in your blood sugar that at least for a period of time, your body can compensate for a raise in blood sugar after you eat rice with raising your insulin. But eventually your body doesn't listen to that insulin, and you have to get higher and higher amounts of insulin to keep the blood sugar down to safe levels. And then when you become hyperinsulinic, then you get other problems. And one of the biggest things is there's a high correlation between people who have diabetes and have heart disease. So it is a path to go down. When they say that stuff is killing you, it's a slow death, and might even be a pleasurable death. But I would suggest that you can find other foods that would give you just as much pleasure and maybe wouldn't wreak havoc with your metabolism. It is one of the biggest things that keeps us from stopping whatever our favorite food is that it gives us so much pleasure, and it's scary thinking of life without that pleasure. And it sometimes, if you just go for 30 days without that food, knowing that at the end of the 30 days, you can have it if you want. So it's not forever. Sometimes that is more palatable, so to speak. You're able to do that 30-day challenge, and maybe at the end of that 30 days, you're going, life was still good even without X food. So you can try something like that. Just say it's for a short period of time, and maybe it'll work out. No, I think I really want to have it. Then, you can always still have it.
And I'm gonna jump in
but
now.
What about the solution, like having 1 month without and 1 day with?
I think you'll find it's harder to go out if you keep having that 1 day. It is that little bit. It's like having that one cigarette. It makes it hard to not smoke in the days between.
Well, I'm sorry.
Paul, let me just jump in 1 second, because I want to just give different perspectives. I think I agree largely with what Leslyn said there, but I'll give an example. The guy hanging on the wall behind me, that was my dear old dad. He lived to be 96. He really wasn't sick a day in his life until 3 days before he died. And he never became a diabetic. He was never obese. His BMI was always normal. There wasn't a single day that went by that he didn't eat bread and rice. He was born in Iran. He grew up on rice. He was, weaned on rice. His whole culture ate rice. So, and he ate a lot of rice. My wife can attest to that. Not small portions of rice, a mound of rice that was the base of the plate with stew and meat and grilled meats and things on top of it. So part of it is, as I said before, we give people general health advice based on good judgment and good science, whatever. But then there's also something that we've learned. Again, it's highly genetic, but it's the biochemistry of our own body. Just as some people are lactose intolerant and some people are gluten intolerant and some people are allergic to peanuts and some people have alcohol dehydrogenase reductase deficiency and can't drink alcohol without becoming violently ill, and other people are prone to alcoholism and other people are not. I had a professor in neurosurgery, Dr. Jonathan Lescarton, was a brilliant guy trained at Columbia. He used to say to me all the time, Truback, I'm not sure we understand everything we know about this. So it was an interesting kind of a thing. In other words, if rice is okay for you, if you go to the doctor and your hemoglobin A1C is always stone cold normal, your fasting glucose is stone cold normal, you're thin and slim and fit, your BMI is normal, and you're not seeing any ill effects in you, then it's probably okay for you. But if you are finding that, as we pointed out earlier, I had patients from the Indian subcontinent who were normal and below normal BMI, and that person's blood sugar is raging, then I don't suggest they eat big piles of white rice anymore. So part of it is practical and experimenting with what works for you and your own body, and what might work for you might not work for your brother or your wife or your son. And that's part of the fascinating part of medicine. And that's why so far we haven't been replaced with AI, because it still takes a sentient being who knows how to practice the art of medicine and look at every patient as an individual and tailor a treatment plan, advice, care, etc., to each and every one of us. If it was as easy as this is what you eat to be healthy, then we'd all be out of a job. They'd write it down somewhere and it'd be all over.
Yeah. Well, I was going to say, on the one hand, I'm really sorry that I asked that question, because if my friends and family hear the answer Dr. Keith gave, I'll be in big trouble. On the other hand, I'm glad I asked, because I got some really good information out there. So I guess it's a win-lose situation, right, John?
Oh, it's a win-win. We're always winning here. We're here to learn and to share and to discuss and raise awareness. And I think, I always say we're not looking for disciples. We're looking for students. We don't have any movement to join. We just bring good people together to share, good ideas that are evidence-based, science-backed, and hopefully little by little, the LymphCast podcast helps everybody to grow and to improve, and we get closer to whatever that unattainable real truth is. But I think it's been another fascinating and amazing discussion. Catherine Seo highly recommended you, Leslyn, to the program. So we've been long awaiting your appearance here. And I know I can speak for everybody where I say we would love to have you back again. I also want to thank Monica Klavitsky for encouraging once again Diane Truback for being on the show, because she's really terrific and she adds a lot to the program. And I hope that she'll be a regular attendee, because I think it's much nicer with her. So
very much. That's very sweet. I love
Monica's always calling for you. Always calling.
Thank you, Monica.
Well, you have a wonderful scientific brain, and you bring not only the brain, but all your kindness, your smile. So it's all the advantage for all of us.
And I also know that as you become a regular on the show, Monica has it in her mind to push me out, which is another subject.
No, that's
No,
not
just
true.
teasing.
No.
Wonderful, wonderful. So who's gonna take us out and thank Leslyn and say goodbye and get ready for the next program?
All right, I'll go around the table and first of all, thank our producer, Dr. Diane Chubak. Diane, thank you very much for everything, putting the show together and for being here tonight.
Thank you so much, Leslyn. We have enjoyed having you on tremendously. I mean, like I said, you are an incredible educator, wealth of information that we've learned here today. I'm sure all of our listeners are, very happy that they know now what they do. So thank you so much. And yeah, Monica.
Thank you. I really enjoyed it. Thank you so much. I'm definitely going to be a regular listener to your podcast.
Oh, very good. I'll
you.
have a bowl of rice next time, John. Would you like to join me?
I'm having pasta.
Okay.
No, don't be bad. Leslyn, can you share with everybody one more time where they can find you, your books, and the best way to connect or follow?
Sure. You can go to my website, leslynkeith.com. And also I do a lot with Lymphedema Simplified. And so that's lymphedema-simplified.com. Either one of those places, you'll be able to get in touch with me. If you want to email me, that's Leslyn Keith OTD at gmail.com. And because I have an H on the end of my name, people think I'm Leslyn Keith Hot, but it's supposed to be OT. So Leslyn Keith OT at gmail.com.
All right. Very good. Thank you. Dr. Golovitsky, thank you for everything tonight. We'll see you next time.
It was an excellent episode. Thank you, Leslyn. And I'm looking forward to receiving your book and to read it from the one page to the last one. Because
Thank you so much.
Thank you.
All right. And Dr. John A. Chubak, founder, owner of the Chubak Vein Center, also Vita Support MD. And don't forget what they sell there. Vein Formula 1000, Lymphatic Formula 1000. Dr. Chubak, thank you for everything, sir.
Thank you very much, Paul. Leslyn, thanks for being with us. We're all following you on social media, LinkedIn, and all of those other good places. Please keep up the good work, keep educating, raising awareness, and we would really, really love to have you back. And what might be a lot of fun would be to have Leslyn with Catherine together on the program. That would be a dynamic duo. They're a great pair.
That sounds great. Catherine and I always have fun when we're together.
Yeah. Thank you so much.
Two great collaborators, for sure.
Mm-hmm.
Yep. Sounds
Thanks.
terrific. Again, visit our website early and often, lymphcastnetwork.com. If you have a question, send it in. Email hello@lymphcastnetwork.com. We're on every podcast platform. We're on YouTube. This has been the LymphCast Show, episode 63. We'll see you next time for episode 64. Thank you for joining, and have a good night.